Hey everyone, thanks for joining me on part one of our concussion series, which is going to focus a little bit more on the big picture overview of concussion, give some good definitions of what constitutes a concussion-based injury. We'll walk through some of the common signs and symptoms of concussion. We'll kind of go through a little bit of the examination, organization and design for someone post-acute concussion injury, and outline some of the prognostic indicators for more of a positive or negative recovery. Okay, so the first thing to keep in mind about concussion itself is that there's typically no major structural injury on an MRI or CT scan, something like that. Okay, so something that makes concussion unique is that there isn't macro level damage on imaging studies. Okay, that doesn't mean they don't have significant signs and symptoms. It just means that it's more of a milder form of traumatic brain injury. Considering the moderate to severe forms of traumatic brain injury, those are typically significant structural damage seen on MRI compared with an MTBI, or a mild traumatic brain injury, which is the alternative name of concussion. Again, big point to consider is that in addition to that no structural injury, typically the signs and symptoms of concussion will resolve within about 10 days. So that's really the first major diagnostic criteria for concussion. Now, there's a lot of individuals that have persistent symptoms related to concussion, and they're probably a little bit more appropriately diagnosed as post-concussion syndrome, not concussion itself. So the rest of this particular lecture will kind of go through those related specifically to concussion, more of the acute phase of injury, and then part two we'll get into a little bit more of the post-concussion syndrome population. Here's a nice link if you're somebody that really likes the pathophysiology of things, so you can kind of see how individuals might have signs and symptoms related to the nervous system because of a concussion without actually showing macro level injury on an MRI. Who's most at risk? Pretty much males and military service members are the ones that are identified as the largest risk of experiencing a traumatic brain injury of any level of severity. O'Sullivan says about 1.1 million ED visits are attributable to a TBI each year. That would include mild, moderate, and severe types of traumatic brain injury, although about 70 to 90% are considered mild or concussion related. So really the majority of the TBIs that the general population is receiving is in the form of a concussion. Leading factors associated with a traumatic brain injury, interestingly, falls as the number one cause of concussion-related injuries. There's a lot of talk about sport-related concussion in society today, and while that's a huge component of things, it's still not the number one leading reason why you might see a patient for concussion treatment. Motor vehicle accidents are also very common, as is things along the lines of violence, assault, with sports being another major category. Okay. The CDC estimates about 3.8 million sports and recreational concussions occur each year, and that's doubled. And I'm curious as to why that's doubled so much over the past 20 years. I don't know if it's just that overall the incident rate really has increased, or if we're just a little bit more hyper-focused on diagnosing it, or if it was just very underreported before, which I have a feeling it was probably more of an underreporting of what's really happening in concussion, because athletes are not great at wanting to be pulled out of play. Unlike the general population, where males are significantly more at risk of a concussion, when we break it down into a sports-related concussion category, female athletes are actually at higher risk than male athletes when you're considering gender-matched sports. This is a really important slide for you to keep in mind. Common signs and symptoms of a concussion. Again, we're talking about those that are most commonly reported within that 10-day window after the injury mechanism. And your top 5, you'll see there headache listed number 1, 94.7% reporting rate of headache. So that should lead you to have the kind of in the back of your mind as we move forward throughout the rest of this lecture series that, you know, differential diagnosis of headache is going to become really, really important if you're working with a patient population that involves concussion, because there's so many different types of headache presentations out there. You really will need to be good at being able to differentiate whether that's coming from the cervical spine, from a migrainous standpoint, cluster headaches or tension-related headaches. There's a lot of different types of presentations that someone with a headache might present with. So differential diagnosis of headache is going to be really high on your list to treat a patient post-concussion well. Okay, dizziness and difficulty concentrating are also really commonly reported, as is sensitivity to light and noise. You can see there's a few other types of signs and symptoms that are commonly reported, but I think it's really nice to be able to key in on those top 5, since those are going to be the most common. If you're, going to work in acute care, or somebody who's going to consider doing like a dual PT athletic training type of degree for your future, then this next component of things might be a little bit more valuable to you. If you're someone that's going to be working more in outpatient facilities, or even acute rehab, long-term rehab kind of situations, you're much more likely to treat individuals that kind of fall in that post-concussion syndrome category, or people that are about more like 2 to 3 weeks post-concussion as opposed to immediate. Okay, so this next section, we're going to focus a little bit more on what do we do when that person has an immediate concussion. What are some of the steps and procedures that we want to do to protect that person moving forward? Okay. One of the first things we need to identify is any red flags, any dangerous signs and symptoms that might require further medical workup. And again, if you'll kind of think back to that first slide, what you would anticipate with somebody with a mild traumatic brain injury, they would have no major structural damage on an MRI. So there's really no need for significant medical workup for somebody that has that mild traumatic brain injury. But if you start seeing some of these other dangerous signs and symptoms, they're probably a little bit more along the lines of a moderate or severe traumatic brain injury, in which case there might be a very different treatment plan that is in store for that person. So that's when you're going to want to refer them to the emergency department for further workup. The other thing to keep in mind is that if the individual who's had the concussion has lost consciousness, it's really important that you assume a cervical spine injury is present until proven otherwise. So until they can become more alert and able to answer questions, and you can start kind of working through the process of ruling out a cervical spine injury, it's really important that you assume it's there, stabilize the head so that you don't create a spinal cord injury at the cervical spine region as well. Okay. As far as sports-related concussion exam goes, it's really nice if those athletes have had some preseason or baseline assessments done, especially from their cognitive performance standpoint. That way you can, be able to compare where they might be at post injury to their pre-assessment, right? And thinking that somebody with a concussion might have, a little bit more cognitive delay or difficulties with visual processing. It's hard to be able to identify that if you have no pre-existing numbers to compare that with. When they didn't have an injury at all. So a lot of these things like the standardized sideline assessment, we'll talk about the SAC and the SCAT-5. Those are two that you can do a preseason assessment with, and then you can have those numbers to compare and contrast with. That might give you more information about how likely they are to have a concussion. Some bigger picture things, try not to leave the player alone. You want to do a serial assessment. In other words, you want to do assessments fairly regularly over the next probably 4 to 8 hours in order to detect whether or not that person's condition is deteriorating. If you start seeing greater signs and symptoms that you might consider dangerous, that's when referral to the ED is necessary. Okay. Big picture thing on the bottom, do not allow return to play on the same day. The SAC is a standardized assessment of concussion. It has some really good categories of testing with regards to things like neurologic screening, overall symptomology with exertional maneuvers, short-term memory, and long-term memory recall. You can set up overall scoring for them both preseason and then post-injury. It has really good use in the detection of a concussion. This is much more important to use in an acute concussion injury. It loses some of its value when we start thinking about post-concussion syndrome, 2, 3, 4 weeks down the road. The SCAT-5 is another really, really commonly used assessment measure for someone post concussion injury. There's two versions of it. If you're over 13 or 13 or older, you'd use the adult SCAT-5 version. If you're under 13, you would use the child version of it. And again, it's just another one of those tools to be able to implement in order to decide, is a concussion present and should I remove the athlete from play? So you see this most commonly directly post-injury, maybe like on an on-field assessment, so to speak. It's got those red flags built into it, some of the observable signs. It's got the Glasgow Coma Scale built into it and a cervical spine assessment, among other things. There is actually an off-field version, like an office version of the SCAT-5. So if your patient is a few days removed post-concussion, you can still utilize this particular tool. It doesn't have to be an on-field version of it. It does include the SAC, which we talked about a couple slides ago, and it has a little bit higher level of balance assessment on their neurologic screening. So it is still an effective tool to use, even if it's not immediate sideline application. Let's talk a little bit more about off-field examination of concussion. There's a few things that you really want to keep in mind if you're going to see a patient post-concussion injury. And the first thing is you got to rule out serious neurologic injury. Remember, the mechanism of injury for somebody with a concussion is most likely going to be traumatic in nature. Okay, so I know you guys are going through a little bit of cervical examination and things along those lines in your orthopedics courses. So, think about some of the tests and measures that you want to do to rule out significant neurologic involvement in a patient that presents with neck pain. Okay, so you might want to rule out things like a moderate or severe TBI or any signs and symptoms of upper motor neuron injury. So things along the lines of like making sure you're doing reflex testing, cranial nerve assessment, assessment for tone and spasticity. None of those things should be present in a person post-concussion. A mild TBI should not create true, honest upper motor neuron signs and symptoms. If you want to throw in a Babinski test or Hoffman's test, those should be negative. Okay. A neurocognitive screening is really, really, really highly important for this particular population. Again, if you can get a baseline assessment, that's wonderful. The Impact is a online computerized neurocognitive screening tool that's commonly used in concussion management, and a lot of athletic teams already encourage individuals to use that in their preseason workouts. But for those that are not a sport-related concussion, it's very uncommon that someone would have a pre-existing impact test for you to be able to look at. Typically, the only other people that would have that score are people that have had previous concussions and have used that from their previous injury. Okay. As far as balance assessment goes, there's two really common balance assessment tools in the research for post-concussion. One's called the BEST test, and the other is the HIMAT, which you've actually already have administered before. From vestibular screening is also really commonly recommended because they bump their head, and obviously that could lead to higher incidence of BPPV for this particular population. Okay, and two major screening tools for oculomotor function is going to be the King-Devick test and the VOMS. I would highly recommend the VOMS because it's free. The King-Devick is great, but it's not free, and I think there's a little bit more clinical utility for the VOMS, which we'll talk about another time. Okay. So again, when you're getting into examination of the cervical spine, as I said before, make sure you're ruling out any major cervical red flags. So think about things like your Canadian C-spine rules. Make sure you're doing your checks for upper cervical instability, like the modified Sharp-Purser test is going to be indicated. Be sure to rule out cervical arterial dysfunction or VBI. Those are really important things to make sure that you're ruling out before you do any further testing with this person. Even probably before you do cervical active range of motion, I'm probably going to rule out upper cervical instability and VBI right away. Okay. Also, cranial nerve screening is very indicated for this patient population, and psychological factors contributing to the patient's symptoms are things that you're going to need to explore or potentially refer. Okay. So why are cranial nerves screened for individuals post-concussion? Probably the most important reason is that a lot of the common signs and symptoms post-concussion overlap with cranial nerve dysfunction. So things like headache could be from the concussion itself, or headache can come from, trigeminal neuralgia or, things along those lines. So it really does give you a nice idea of how to help differentiate whether the symptoms might be coming from an existing cranial nerve problem, or if there's any cranial nerve dysfunction occurring with this person in addition to their concussion symptoms. It's best practice to have a comprehensive assessment of the patient's neurologic status that has to include cranial nerve assessment. So I threw in this little table here, hopefully to kind of help group everything together about what the different cranial nerves are and how we're going to kind of go about general testing for them. And this is something that we're going to do in lab. We're going to go through some of these major ones. We won't go through all of them. Like, I don't know how important it is for us to actually practice olfactory. I think we could talk through that and have a pretty good idea about how to test that. So we'll kind of go through some of the really big picture ones that we feel like we need a little bit of psychomotor practice performing. If the concussion is due to a fall, then there's probably a few additional things we want to put into our examination of the patient. Obviously, from a subjective standpoint, we want to ask about any circumstances of the fall, what was going on that led to the fall. Maybe the patient has some ideas about contributing factors for it. And then you want to ask, or at least examine if you can, the patient for other injury sites. Maybe they fell and landed on their shoulder. Do they have a shoulder injury in addition to the concussion because of the fall? So rule out other, musculoskeletal injuries and integumentary issues, things of that nature. Okay. Also want to assess for any sort of cognitive changes or amnesia that might have occurred during this particular event, and that becomes really important when we start considering prognostic factors. So balance exam is going to be a further essential component of somebody that has a concussion related to a fall. You might need to do a deeper dive to differentiate the root cause of the fall. And then for somebody that has persistent pain, more along the lines of post-concussion syndrome, we're going to talk about the need for being able to screen for subtypes. If somebody has fallen and was able to get into, a medical environment where you can see them within 10 days, then we won't need to really worry about classifying for subtypes. But most commonly, from someone that's had a concussion due to a fall, most of the time you're going to be seeing them 2, 3, 4 weeks down the line. So if they have persistent concussion symptoms, then stay tuned in part 2 for a little bit about how we start working towards subtype classifications. Okay. The only time you would really want to consider referral for a CT or an MRI is if you do suspect more serious injury, more like a moderate to severe concussion. Like we said, CT or MRI are insensitive to a mild traumatic brain injury, but will be sensitive for moderate and severe. Okay. There are some other types of imaging that has been thrown out there in the research. Most of it's just mixed results. Advanced imaging has been okay, but not great at really confidently diagnosing concussion. Serum and plasma biomarkers has been good, but to be honest with you, the best way to truly identify whether or not somebody has a mild traumatic brain injury is going to be clinical presentation of signs and symptoms along with differential diagnosis to rule out more significant causes. So a comprehensive examination process is important. You really need to listen to the patient to get a thorough patient history. You want to identify injury-specific risk factors, anything that might have related to the source or root cause of the injury itself. Then you might want to screen for constitutional risk factors. These are things that are inherent to the patient, maybe their prior conditions, something like their age or gender, because those do play a role in how likely somebody is to have a positive recovery post-concussion. Okay. All of this to say, a lot of these particular factors contribute to the likelihood that someone will have a positive prognosis. Okay. And so already thrown out there, the younger the person, the better off their recovery process is likely to be. Okay. If you're in the general population and your age is starting to increase, a lot of the research is showing that they're the ones that are most likely going to have a prolonged recovery. Or said differently, all the factors that are listed on here are factors that might increase somebody's risk of developing post-concussion syndrome 2, 3, 4 weeks, even longer down the road, still managing concussion symptoms instead of having that nice 1 to 2 week recovery process. Okay. Female gender, more associated with prolonged recovery. Some of these are pretty straightforward, right? A higher the symptom magnitude, the more likely my recovery is going to be prolonged. Here's a big one for sport-related concussion, delayed removal, allowing that athlete to continue playing even though they have signs and symptoms actively of a concussion is most likely going to create a prolonged recovery for that particular person. Okay. There's some additional interesting ones like depression or anxiety or other pre-existing mental health problem, most likely going to produce prolonged recovery. History of migraine typically delays recovery. So there are quite a few things on there. From our standpoint, as we get into kind of classifying individuals with regards to clinical symptom profiles, It is important to note that if they fall in that vestibular or ocular category, they are way more likely to have a prolonged recovery. In fact, on-field dizziness is predictive of recovery taking 3 weeks longer than the average. Okay, so dizziness, visual disturbances, things along those lines, more likely going to lead to a prolonged recovery process. And that's the big components of the overview of concussion itself. Thanks for paying attention. And when you're ready, jump over to part 2, and we'll start getting into a little bit more conversation about what to do with someone that has post-concussion syndrome, which is probably the majority of the types of concussion patients you're likely to treat as physical therapists. Thanks.